Hello, welcome to the Cancer Informant. I'm Dr. Tony Magliocco, and I'm the Cancer Informant. Today's episode is going to be about precision oncology and what it means to you. We live in an exciting time where scientific advances are really amazing, and they're starting to impact human health. One of the most important advances in the last, I would say, 100 years is probably the completion of the human genome sequence, which really uncovered the human blueprint and gave us information to understand almost every human disease. That information is now impacting our care of cancer patients. Cancer is now moving from a one-size-fits-all treatment to what we call precision oncology. What does this mean for you as a cancer patient? Well, it's really important. Back in the old days, when a patient had cancer, the options were very limited. Basically, there was surgery, chemotherapy, and radiation. As we learned more about cancer, we learned that there were targeted therapies, that cancers are different from normal cells, and that they're being driven by different sorts of growth factors and oncogenes. A good example is breast cancer. We knew a long time ago that breast cancer, or at least many of them, are probably driven by estrogen receptor. And that if we block the activity of estrogen, we could actually slow the growth of breast cancer. It was observed that women with breast cancer, if they had oophorectomies and their ovaries removed, that the breast cancer would sometimes stop growing. This led to the discovery that if you use an anti-estrogen therapeutic, one of the first ones was tamoxifen, that you could block the growth of breast cancers that were driven by estrogen. Hence, estrogen is now measured in every single breast cancer to determine if the tumors are estrogen receptor. Estrogen is the hormone, and the tumor cells have a receptor called estrogen receptor. When the hormone binds the receptor, that causes the cells to divide. It's like a lock and key. The hormone unlocks the estrogen receptor, activating it, causing cellular growth. We also know that breast cancer have other factors such as HER2. Interestingly, we don't quite know why some breast cancers have amplified HER2, where the cell gets many copies. And those activated copies of HER2 cause the cancer cells or the breast normal cells to turn into cancer cells, which then multiply and divide and spread through the body, causing all of those problems of metastatic cancer. Now, what does it mean in terms of a patient about precision oncology? Well, one of the problems about precision oncology is for effective treatment of a cancer patient, there's actually hundreds of potential therapeutics now. There are many different kinds of medicines and drugs and different kinds of immunotherapy. And to use the right one really requires proper diagnosis and assessment of the cancer to properly match a patient to the right treatment. Now, these treatments, these precision oncology treatments, are truly revolutionary because, first of all, they're very specific for the cancer. So often there is only minimal, what we call off-target effect, so that we can effectively target and poison a cancer without really seriously affecting the surrounding normal cells. Now, when we look at conventional therapy, such as chemotherapy, chemotherapy affects normal cells as well and can cause serious side effects such as bone marrow suppression, hair loss, cardiotoxicity, etc. So if we can find the weak spots in a cancer, the real cancer targets, we can really select therapeutics that will essentially target the cancer and leave the normal cells alone, giving a very, very good outcome. One of the best examples of a tumor that has really seen a lot of advances with precision oncology is lung cancer. Now, lung cancer back many years ago was really classified by looking down the microscope, that we could classify it into glandular type lung cancer, which we call adenocarcinoma, squamous type lung cancer, and small cell type lung cancer. And really, that was the only classification we had. About 15 years ago, we discovered that many lung cancers are driven by activation of an oncogene called epidermal growth factor receptor. Interestingly, the cancers that had this particular alteration were more likely to occur in Asian women who were non-smokers. And this really led to a revolution in both diagnosis of lung cancer and creation of therapies. Over the years, we discovered that lung cancer also had other driver mutations. For example, ALK fusions, RET fusions, and other types of unusual genetic changes that occur inside of the cancer cells that drive it. These unusual fusions, some of them NTRK 1, 2, and 3, led to the development of specific therapeutics that really target lung cancer with those particular mutations. Now, that's all well and good, but the real challenge is we can only use those therapeutics if we know that the lung cancer actually has those mutations. It might surprise you to know that in the United States, the majority of lung cancer patients do not have the testing required to match them to targeted therapies that are actually approved by the FDA and generally covered by insurance. And this is one of the looming gaps in cancer care. There is a significant and growing gap in access to precision oncology. If a patient goes to a leading academic center, the treating physicians at those centers tend to be very up to date with knowing the correct diagnostics to order and to have available the right therapeutics. In addition, they have many clinical trials that might be available where the entry is governed by knowing about a particular driver mutation. Clearly, if a patient does not have the right testing, they will not get offered those treatment opportunities. And I think that that is one of the biggest barriers affecting cancer patients today. I would advise a cancer patient to ensure, first of all, that their diagnosis is correct. And I talked about that in another episode, an earlier episode of the Cancer Informant, where unfortunately, primary pathology is frequently incorrect or incomplete. And by incomplete, I mean that the correct molecular tests were not ordered. This could be because the physician was unaware that there were new tests available, or it was very challenging to get those tests. Perhaps there wasn't enough tissue available to run the test, or that the gene panel that was available did not include all of the markers that are linked to therapy. You can see this is a very complicated type of analysis, and it's becoming more and more complicated. There are actually now hundreds of companies, pharmaceutical companies, developing targeted therapeutics against many different targets in cancer. These companies are offering clinical trials that can be very effective. However, to be eligible for one of these trials, you would need to qualify on the basis of having the right mutation to make you eligible. If you don't have the test, there's no way you can be eligible for those studies to get access to innovative and potentially very effective therapy. I think this is a significant problem, but one that patients can really take into their own hands. If they're aware that testing was not done on their case material, they can request that testing can be done. They can actually contact labs and arrange for testing to be done on their materials, or ask the oncologist to arrange for additional testing to be done. Now, what sorts of materials can testing be done on? Well, first of all, the biopsy. That's obviously the most important piece of material. So when a biopsy is taken of a cancer, it is sent to a pathology lab. A pathologist will examine it and make a diagnosis. It may surprise you to know that that material will then be stored. So the stuff that's left over, the biopsy material that's left over, is stored for at least 10 years. So this means you can actually go back to it and take additional sections and have molecular analysis done. Sometimes there's analysis that requires something called immunohistochemistry. That's where a stain is applied to the tissue, and something such as PD-L1, a marker of immune resistance, can be measured, and then a patient can be qualified for a treatment with an immune therapeutic. Another type of treatment is based on the germline. So this means if you have inherited a certain kind of genetic alteration that predisposes you to cancer, for example, breast cancer based on a BRCA1 or 2 mutation, that you would be eligible for treatment with a new type of therapy called PARP inhibitor. And PARP inhibitor therapy can be very effective in women with breast cancer, ovarian cancer, and actually also in men with prostate cancer, pancreatic, and other cancers. Now, the barrier is you actually have to have the test done. And remember also, not all tests are equal. So some genetic tests may only look at 3 or 4 genes, and they could miss the gene that actually directs the therapy. I recommend that my patients who are undergoing genetic testing have a very broad panel, and I would prefer that they have a whole exome done. A whole exome means that they can measure 22,000 human genes that cover all of the human genes, and that information is now available in the health record of the patient. They can refer to that information and get information about their cancer risk genes, but that also has information about other genes that guide therapy, like I told you, the BRCA1 and 2, et cetera, but also genes that cover mismatch repair that drive something called Lynch syndrome. And they can also uncover information if they do carry other types of cancer syndromes. And this can be very important. If you carry a gene that dramatically increases your risk of cancer, you may need to modify your screening approach. Because if you're very likely to get a colon cancer at a young age, you may need to start screening much sooner. And even after you get a cancer, you're at risk of getting additional new primary cancers. So you must be very vigilant about getting those cancers at an early stage. Remember, getting a cancer at an early stage can mean the difference between life and death, where you can actually take an intervention and cure that cancer at that early stage with surgery. So precision oncology is very important. Now, what happens if you don't have that biopsy? Now, not all hope is lost because there's something called liquid biopsy. And in a liquid biopsy, which is essentially a blood test, we can take a blood sample and measure both circulating tumor cells and cell-free DNA to determine, first, do you have any cancer still in your body? That's important to know. So perhaps the primary surgery actually cured you and there's no residual cancer. But if you do have residual cancer, having a liquid biopsy can be very effective to tell what sort of cancer is remaining. If the circulating tumor cells are there, and for example, if you have breast cancer, we can measure targets in those circulating tumor cells, PD-L1, estrogen receptor, HER2, so we can get information about modifying the treatment. And then we can adjust treatment and then monitor the blood in the future to see if the treatment is working. Also, the second component of the liquid biopsy, the cell-free DNA, will read out other actionable mutations. So in lung cancer, we can read out, does the patient have EGFR mutation or a targetable KRAS, such as G12C, or other types of mutations that are linked to therapeutics. So the future is very bright for patients with cancer, and we're really moving towards precision medicine. So in summary, what is precision medicine and precision oncology? Well, basically, that's moving from one-size-fits-all treatment using standard chemotherapy, radiation, and surgery towards a more precision approach where treatment is selected for the individual patient based on a molecular profiling of their tumor and their genetic information. Doing this is very important because a very effective treatment can be selected, and often these treatments have less side effects. Sometimes these treatments need to be combined with conventional therapy as well. Now, remember that a patient will not be eligible for these treatments unless they actually have a molecular profiling, and a complete one at that. So the message is it's very important that if you do have cancer, that you do have a proper diagnosis and a proper molecular profile. With a proper diagnosis and molecular profiling, it opens up more treatment opportunities for you as a patient, and also potentially opens up entry onto effective and innovative clinical trials. Please visit our website and leave comments and rate our podcast. Also, if you have any questions, please leave those questions, and I can attempt to address and discuss them in a future podcast. Thank you for listening, and have a wonderful day.